Well, good afternoon, everyone. First of all, I would like to thanks organizers, especially Dr. Vikas, for giving me this opportunity. And as rightly said by Manju ma'am, febrile neutropenia it's the most dreaded complication of cancer therapy, cancer chemotherapy. So I welcome all my esteemed panel members, and we have uh, all the specialities: infectious disease consultant, microbiologist. We have onco nurse, and then we have all the hemato-oncologist, medical oncologist. As rightly said by Mopatra sir, that it's difficult to cover, febrile neutropenia in half an hour. This will minimum require 2 days to cover entire topic. And after listening to Dr. Manju ma'am's lecture, I'm sure we'll be a great discussion now with this febrile neutropenia. So just a basic, I'll ask Dr. Anant, yeah, what is febrile neutropenia? Just to brush up, I know everyone knows what is febrile neutropenia. So can you exactly define what is febrile neutropenia?
Febrile neutropenia is defined as a temperature more than 101 or persistent fever of more than 100.5 in somebody who is neutropenic with a count of less than 500 neutrophil counts, and or who is expected to have neutrophil count less than 500 in the next 48 hours. That would be the definition of febrile.
Yeah, exactly. So that is what is defined febrile neutropenia. Count less than 500 or expected to fall further with fever more than 101. So, ma'am, Bhavana ma'am, can you define what is profound neutropenia?
I think similar caveats along with an absolute neutrophil count of less than 1
Yeah, less than
or
100.
500.
And we did listen to ma'am's lecture about functional neutropenia. So, can anyone define what is functional neutropenia? Maybe Dr. Samir Thalp. What is functional neutropenia?
So, as a hematologist, typically we see this in sort of MDS,
Exactly.
where you may have
Yeah.
sort of a normal and near normal neutrophils, but because it's a stem cell disorder, functionally the neutrophils are not doing the work that they should do. So, they almost the patient is at risk of being neutropenic or profound neutropenic actually.
Yeah, so exactly. Even though the neutrophil counts are normal, but this is because of impaired phagocytis and killing, there's a functional neutropenia. Yeah. So the most important question: why it is so important? Why febrile neutropenia is important? Yeah, any of the panel member can take this.
So I think it's febrile neutropenia is very important because it's a medical emergency, and there is a lot of data to show that if there is a delay in administration of antibiotics, there is increased mortality.
Yeah, exactly. And is it important in both solid and hematolymphoid malignancies? Yeah, is it important, ma'am, in both solid and hematolymphoid malignancies? Yes.
So yes, it is important in both solid and hematological malignancies, except with the new CDK4/6 inhibitors which have come in. So which is where the definition of functional neutropenia comes in. That even though these patients, they are neutropenic, they usually don't tend to get admitted with febrile neutropenia.
Yeah. So exactly, we know that the solid tumors almost 10 to 50% chances of having toxicity, febrile neutropenia, and whereas in hematological malignancies, more than 80 patients get this febrile neutropenia episodes. And with this febrile neutropenia, there's compromised clinical outcomes, there's chances of increased mortality, prolonged hospital stay, increased cost of treatment as well as diagnostic, delayed chemotherapy courses, and chemotherapy dose reductions, which we normally follow whenever we see any patient having febrile neutropenia with grade 4 neutropenia. We tend to, reduce the dose by 10 to 20% if at all this is grade 4 neutropenia. So, and I asked, Dr. Rahul Kulkarni. Yeah. So, how many patients with febrile neutropenia have actually documented infection? Maybe Dr. Om Srivastava. Yeah. So, how many patients with febrile neutropenia actually have a documented infection?
That would vary from for a number of reasons, depending upon how robust you have started implementing the guidelines when the neutropenia started. How good is the laboratory? Somebody mentioned how much blood you should collect at the initial part.
Exactly.
If you collect 2 sets of cultures, the yield is anywhere from about 40 to 60%. But if you collect 4 sets of cultures, that yield immediately climbs to about 95%. I personally feel that there is very little role of an anaerobic culture, but when you're doing a febrile neutropenia workup, then you should correct both. So 10 mils of blood in each of these bottles will give you a potential yield of about 90-95%. How many of these patients, again, it would vary from center to center, but I would think anywhere from about 40 to 70% will show the documentation of an infection.
Yeah. So
I think when you say documented infection, it could be two. One is you catching up in the bloodstream, and second would be a documented infection where your blood, your cultures may be negative, but you may have a system involved.
exactly.
So here also it would vary if it's a solid tumor, a neutropenia, which is a transient neutropenia for 5 to 7 days, which happens in solid tumors. I think there it is more usually a febrile neutropenia. But when you have an AML or MDS or hemolytic stem cell transplant neutropenia, which goes on for a prolonged time, like 2 weeks or something, there possibly 30% of the times or 40% of the time you may see severe mucositis or perineal abscess or excoriation, or you may see a severe neutropenic enterocolitis. So there possibly you may see, or you may see a patient having cough and breathlessness because. So there, but chances of blood culture coming positive would be much lesser overall.
Yeah, so exactly. So literature does mention almost 50% of the patient doesn't have any no infection is found. Whereas in 30% it is microbiologically documented, and 20% there are clinically documented infection. So can you tell me please what is the frequency of infectious agent in neutropenic cancer patients? Yeah, Dr. Vasant.
Normally, catching up an infectious agent in a blood culture or in a pus culture, whatever, site culture is very, very not, I would say hardly 20 to 30% or less than that, I would say you get it. Majority of the patients, in spite of having severe febrile neutropenia or even sepsis, many times you may not get a cultures positive. But I would say it is less than 20% where you have an infectious agent caught up. And I think though Pseudomonas predominates in neutropenic fever, in India, I would say, we have a deadly Klebsiella which is going on.
Yeah. Anand, do you have to say something?
I agree with Dr. Nagvekar that it's gram-negative and mainly E. coli and Klebsiella that is the most common organism in our settings.
Yeah. So mostly it is almost 70 to 90% time it is the bacterial infection followed by fungal, viral and parasitic. So which are the common pathogens we come across? Which are the common pathogens which we come across during a febrile neutropenia? Yeah. Ma'am, maybe you can take that. Yeah.
So before I get to that, I will agree that even our personal studies show that despite doing ample cultures before giving antibiotics, we don't have a yield of more than 20 to 30% on blood cultures. And very often we're just forced to choose empirically based on localization of infection if we can actually pinpoint where it might be coming from. As far as sort of frequency of infectious agents go, among the bacteria, as everybody has pointed out before me, the gram-negatives would definitely predominate in our setting. And yes, I would agree that it has to be the Enterobacteriaceae more than Pseudomonas is what we see. Klebsiella, E. coli, Enterobacter and Pseudomonas. We don't have that much Acinetobacter in our hospital, but I believe it is a problem in other places. And among the gram-positive bacteria, although we always tend to cover for MRSA, especially in these immunocompromised and sick patients, our data shows us that even among the patients with Staph aureus, the MRSA rates are quite low. So when we're giving a broad-based gram-negative cover, we're most often sort of covering for Staph aureus as well, But that would be the most common gram-positive organism, followed by Enterococcus, is what I would consider. And if we're going down to the fungi, it would have to be a toss-up between Candida and Aspergillus based on what kind of cancer we're talking about and what the risk factors for them are.
I'm not sure the questions to be addressed in between or at the end. But in today's world when PCR septic panels are available, answer to any of these questions will change. Do we have more evidence of infection with PCR panels?
Dr. Bharat, it's very difficult to say because the PCR panels, as you know, are extremely sensitive, but we don't know how to actually differentiate colonizers from sort of real infective pathogens on those. And the correlation between the PCR panel and the blood culture is so poor, and you're using the blood culture as a gold standard or another sterile culture as a gold standard, So,
so you will base the incidence of documented infection on blood cultures, not on the PCR, even if it's come positive.
That's the sort of frightening part about PCR, because you don't know exactly what to treat and what not to. But with more and more reliable PCRs coming in the very sick patients, you have no choice but to.
Second thing, regarding the functional neutropenia, we are also using granulocytic extraction and transfusion in case of severe shock. How to differentiate between actual neutropenia and post-granulocytic transfusion normal neutropenia, normal neutrophil counts? If any of you can comment. Hematologist probably you can comment.
Yeah, okay. Can I take that, Samir? Yeah. So when you are dealing with a situation where you are stimulating the total, the bone marrow production of those cells that are going to be protective in this kind of a patient's situation, it's impossible to differentiate. Are you dealing with a situation where the patient is getting better because of your regimen, of your therapy, or the patient is actually having a response to other factors that we don't know enough? Ultimately, you are going to have to decide as a clinician whether you are going to be needing to treat this patient based on, say you've grown a Klebsiella. No, you've done all the diagnostic studies.
Question wrong. I'm not asking in view of GCSF. I'm saying we are giving granulocytes from exogenous granulocytes.
That's the point I'm making. If you're giving granulocytes from exogenous sources,
so how we can differentiate tomorrow?
I'm not sure if there is a defined, specific, irreversibly fail-proof way to determine whether one pathway is working or the other. I'm not sure if there's anybody who would like to comment.
So one way is that if the WBC counts are high because of the granulocyte infusion, it does not last long. The counts that are high because of the infusion would gradually reduce, and by 48 hours it would go back to a neutropenic value. Whereas if it's an endogenous rise, then the WBC count will remain steady. So at one point of time after the granulocyte, you may not be able to differentiate, but the counts would serially fall by the next day or the third day.
So what is the usual in vitro half-life of exogenous WBCs?
So I don't know in vitro, but in vivo it's almost 24 hours to 48 hours.
Okay. Yeah. So I would like to ask Dr. Vasant Nagavekar sir, is there any change in the flora of the organisms causing febrile neutropenia in last decade or so?
Yeah, so
like
So one is, I'd just like to answer what Ayesha said about the septic screen. So I think this is not really US FDA validated. I would say they may not be good or bad, whatever. I think, but we require more and more patients to be sent for septic screen to really validate our own, data.
Exactly.
Now coming to your question, I think though we always talk about Pseudomonas, and we always talk about covering Pseudomonas as an anti-Pseudomonal whenever you have a febrile neutropenia. But in my experience for so many years, I've hardly seen Pseudomonas being into the blood culture or site culture. It's usually the first organism. What I'm always seeing is either it's an E. coli or a Klebsiella, or really Enterococcus, and fourth would be Candida. Yeah. So I think in Klebsiella also, usually we always see a multi-drug resistant Klebsiella or a multi-drug resistant E. coli, or it's an Enterococcus faecalis or faecium, whatever.
Exactly.
Third and fourth is Candida.
Exactly. Yeah. So would like to just ask, what is the main causes for increase in this gram-positive septicemia nowadays? I mean, what are the common source for this gram-positive?
So I think if you ask me, majority of the time it's always gram-negative. So in India, the first problem is gram-negatives.
Yeah.
Second is Candida, and third is gram-positive.
Yeah.
Okay, so gram-positive much lower on the cards. And even if you have to see, guys, what Ayesha said, we don't see MRSA as what is seen in the Western world. We usually see Enterococcus, either faecalis or faecium. Whatever MRSA we see or whatever MSSA we see, it is usually community acquired. Okay, usually skin and soft tissue. And so if you have a febrile neutropenia patient with a skin and soft tissue, boils or, a carbuncle or whatever, then you will see a gram-positive. But otherwise, per se in India, it's always gram-negative Candida, and third would be Enterococcus, and fourth would be Staph. I would say much lower compared to the Western world.
Yeah, exactly. Yeah. So coming to the neutropenic fever syndrome. So first fever in any febrile neutropenia, we know that it is 90% of the time it is because of the indigenous flora. But can someone define what is persistent fever? When we call in a febrile neutropenia patient is a persistent fever, or when do we actually change antibiotic? Like a patient start on first line antibiotic, persistent fever. So what exactly is persistent fever? Yeah, Anant, take this.
So it is basically a clinical decision if the fever persists for 72 hours after.
Yeah, so I just want to know that duration when you actually act. No, this is like, see, there's a two different set of patient. One is a hematological malignancy where you do expect that this is prolonged neutropenia, or one is a solid tumor patient after, say, after breast chemotherapy EC regime, patient present to you on day 10, day 11, and fever not going. So what exactly is persistent fever, and when you decide for the change of antibiotic?
The decision of changing of antibiotics may not only be on the duration of fever. Sometimes the patient becomes visibly sicker, goes into more sepsis, and that would also be a crucial, important point to take into consideration about changing the antibiotic.
Yeah.
So, don't know, practically, I think if we were just talking with Dr. Shona and Sudeep that in solid tumors, actually, we are seeing less and less patients presenting with febrile neutropenia, and we can discuss that if we have time.
Yeah.
Practically, if a patient comes with febrile neutropenia, if the fever hasn't responded in 48 hours to first-line antibiotics, and the other thing is you look at the hemodynamic status, or if the patient starts becoming hemodynamically unstable. So these are the criteria for me to change the antibiotics. So if the fever is persistent at 48 hours, we'd go to second line. And if, again, you do various tests, you repeat the cultures, you do an HRCT of chest, you follow all the guidelines, and maybe add an gram-positive cover if the patient has a central line, and add an antifungal if the patient has not responded after 4 days and remains neutropenic and has had risk factors like diabetes or being on chemotherapy or steroids for a long time.
Yeah. So, ma'am, on the same lines, I would like to ask, see, normally we have a knee-jerk reaction of starting gram-positive. I mean, in a hematolymphatic malignancy, that's okay. But what nowadays, starting gram-positive cover, if the patient has hypertension, say in a solid tumor patient. So, what's your take on that? Should we add a gram-positive as soon as a solid tumor patient with febrile neutropenia coming on day 10, maybe with BP of 80 by 60?
So piperacillin tazobactam is our first line along with an aminoglycoside. But and piperacillin tazobactam, I think we have enough specialists here, does have a good gram-positive cover, but it is not as robust as, say, teicoplanin or vancomycin. So if a patient has a central line and has had for some time, I would actually add it first line.
So even in a solid tumor patient?
Even in solid tumors, and especially if they're hemodynamically unstable. And in fact, I also go by the Institute's antibiogram. So, every 6 months we update our antibiograms, and you know that your patient is not going to respond to, say, piperacillin tazobactam. So in those situations, you end up sometimes starting the patient on meropenem actually as first line. So the institute level antibiograms are very, very important.
Yeah. Yeah. Yes, sir.
I don't know if the other ID specialists will agree with me, but when it comes to gram-positive cover, yes, I agree that we do have a knee-jerk reaction of starting it. And then, as you said, even if it's a solid organ, if it's a hemodynamically unstable patient who comes in, there's really very little in terms of stewardship that one can, control with giving a gram-positive cover. But I think the thing that we can sort of modify is that unlike the gram-negative organisms, in a patient who hasn't received antibiotics before the blood culture is being sent, if we have that culture of, ascertaining that cultures have been sent before starting antibiotics, if your cultures are negative at 48 to 72 hours, you can quite safely say that there is no gram-positive organism, because these are very likely to grow in cultures.
So you can de-escalate and stop at 48 hours.
Absolutely, because as you said, you've got a cover on, you've got a broad-based cover on, which would cover the other things. You don't need an MRSA cover if you have. Yeah. Would you agree with me?
Yeah, sure. Right.
Yes.
Yeah, I think you're right. I think that piperacillin or a beta-lactamase inhibitor, along with an aminoglycoside, is also a reasonable cover if you've not grown anything in the first 48 hours, 72 hours. Unless you clinically feel that there is a gram-positive focus that is getting missed, it's reasonable to de-escalate.
So I think your first slide about the previous slide. Yeah. So persistent fever and the first fever, persistent recurrence fever. So I would. So how would I approach a patient? As ID as a say, patient who is neutropenic and say the hematologist calls me. So the question also comes ki in a neutropenia when the ANC is less than 500, if the patient does not have fever, do you give a prophylaxis in India? Okay. So I think that message also. I don't think there is any role for prophylaxis in India for quinolones or even amoxicillin, clavulanic acid, because the resistance, what we are talking about is predominantly gram-negative, the E. coli, Klebsiella, and the resistance is to the tune of 80 to 90% of ciprofloxacin. So
exactly.
So that's first thing. Second is, say day 4, if your fever continues, okay, so what do you do? So I would, if the patient is clinically very stable, I would still continue the same line, but I would look for oral mucositis. I usually do always a PR examination to look for any perineal tenderness, which patient may not have because of the low neutrophil count. If the patient may not have complaint also, so I would look for that. Look for abdomen. Look for any skin, soft tissue, any small boils coming up and all that. Does he have a perm cath or does he have a port? I think I would look all that for day 4. My threshold for doing a CT would be day 7 beyond fever persistent. That's what I would.
Yes. So exactly. So what I wanted to ask is, ma'am, there's no evidence to give gram-positive in a solid tumor patient if he doesn't have any indwelling catheter or any source of infection. But since it's our knee-jerk reaction, we tend to start gram-positive.
They have a central line. If they don't, then
if they don't have any focus, there's no central line, there's no per se, but patient comes with hypotension. So this is what I just wanted to know. Is there any actual evidence to give gram-positive? Unlike in patient who receive high-dose cytarabine and then present with hypotension, so that's okay. But we tend to start in solid tumor also. Yeah. So we'll just move on quickly to a case. So she is a 57-year-old lady who is a breast cancer patient on adjuvant chemotherapy. So she presented on day 8 of her EC regimen with fever with rigor. So 48 hours before admission, she developed a cough which was productive with yellow phlegm and felt increasingly short of breath, particularly on exertion. She is a known COPD on salbutamol inhalation. So on examination to emergency, she has temperature of 38.8, her pulse is 122 beats per minute, BP is 90/60, saturation is 89% on room air, CBC revealed HB of 9.2, a total leukocyte count of 0.65 with ANC of 0.12 and platelet of 1,12,000. Her liver and renal functions were absolutely normal, CRP is 220 and urine dipstick was negative. So how do you approach this patient now? It comes to emergency. So is there any role of, first how you approach this patient, and then is there any role of risk assessment? Yeah, anyone can take this question.
No. Actually, this is borderline actually 90/60 BP. This is most likely you have to take your clinical judgment in this patient.
So she is a solid tumor patient, sir. Breast chemotherapy, EC regime, day 8 she presented with this febrile neutropenia episode.
And actually she has COPD also.
Yeah, she is a COPD. Her BP is 90/60. Yeah.
BP 90, she needs admission actually.
Definitely.
Immediately after cultures IV antibiotics, you need an X-ray also here.
Yeah. Yeah. Anyone?
So I think though this patient classifies into a low risk, but the presentation is a very high risk.
Yeah.
So I think that low risk, high risk, I think if you can't strictly calculate the score, I think you have to take it as the patient comes.
Yeah, as
so
the
this patient is in sepsis and septic shock.
Yeah.
And possibly
early septic shock. Maybe we can say she is in early septic shock.
Early, she's 90/60.
90/60.
Tachycardia with a CRP high, and saturation of noise. So basically in multi-organ failure. So I think this patient is very high risk in septic shock. So yeah.
Yeah.
With this neutrophil count, she's not going to give you much time. So I would agree with Dr. Nagvekar.
Exactly. So what is the role of risk? Since we have listened in the heard in the lectures previously, risk assessment in solid tumor, the Turcotte's rule, all this. So they are extremely heterogeneous group. We all know many factors influence the outcome as well as the course, and definitely there should be a risk assessment for febrile neutropenia patient. And what exactly distinguishes high risk and low risk patient with fever and neutropenia? Okay. Is anyone? And I would like to ask Sister Anita also. Sister, when such type of patient come to you, so what's your reaction? Like from nursing point of view, I wanted to ask you.
So when patients like this present to us in the casualty, we have a protocol where when the patients come, we initially do the physical assessment to see If there are, like suppose a patient has got a central line, we see whether there is any exit site infection. Then we also ask the patient for history of any abdominal pain, diarrhea, or even the burning micturition. And then we have a protocol that we take a blood culture. And only after that we give antibiotics to the patients. So, and yeah, that's the protocol that we follow here.
Yeah. So, just wanted to know about since we already know this role of GCSF in febrile neutropenia, definitely use of these agents has enabled development of more aggressive chemotherapy regimes, including dose-dense chemotherapy. And so, when should antifungal prophylaxis should be given and with what agents? I'm just talking more of a solid tumor patients. So, we hardly come across giving antifungal, prophylaxis in solid tumor patients. But then I have seen patient coming with grade 4 neutropenia even in a solid tumor. So, when actually one should think of giving antifungal prophylaxis in a solid tumor?
Only with documented fungal infection in last infections. Those are the patients. Otherwise, we don't use in solid malignancy.
So, in a solid tumor, you mean to say only in a documented infection we should start, otherwise we should avoid. Does panel agree to this?
So, we hardly use in solid tumors antifungal prophylaxis. I can't think of a scenario where we do.
Yeah.
Patient presents on day 7 or day 8 of neutropenia with somewhat borderline clinically requiring admission and all. I add antifungals because nadir has not yet achieved. Day 10, day 11 will come when neutropenia will drop further. So in those situations, antifungals, clinically we should add antifungals at present.
So does the panel agree with doctor?
No, I don't
regarding
think,
antifungal.
I think if you know that the duration of neutropenia is going to be shorter, like 5 to 7 days in a solid or in a tumor. So I actually we don't have a tendency to add antifungal unless the patient has a document, say severe mucositis with neutropenia or severe enterocolitis or perianal excoriation, or if the patient has a perm cath or something of that sort. Only then. Otherwise, I think and if you start, then how long will you give? Okay. So the whole thing is best is if you're not suspecting, if you know that neutropenia is going to be shorter, preferably we tend to avoid. And another thing is, I think nowadays you can have this one marker called a beta-D glucan, which will help you to reduce your usage of antifungals. Which if your beta-D glucan is negative, then which it tells you about basically what we are worried about is Candida and Aspergillus. It doesn't tell you about mucor, but it will definitely tell you about Candida. So you can send a beta-D glucan, and if it's negative, you can be 90% assured that this patient may not be having at least a Candida and Aspergillus.
Okay, so just a last question. So what will be the antibiotic of choice in this lady? She is in septic shock. So how you, I mean, as far as antibiotic is concerned, what will be your first choice of antibiotic in this lady?
She has a chemo port.
She has a chemo port. She's day 8, febrile neutropenia, maybe a profound neutropenia, ANC is 112. You have X-ray? Sir, X-ray. She is short of breath. She is a known asthmatic. Yeah.
So the choice would be a beta-lactam, either piperacillin tazobactam. I would also add ticoplanin in this case because she's got a respiratory focus.
Respiratory focus,
COPD,
yeah.
And maybe atypical coverage with azithromycin.
So I'd like to slightly differ here. This patient is in septic shock, and so I'll ask for one is quickly assess where is though the patient's saturation is 18 and it could be an ARDS and may not be the primary lung issue. So look for any other source which is causing the patient to go into septic shock. I mean any sepsis, any organ involvement can cause the patient to go into ARDS and respiratory distress. So first I look to pinpoint which is the syndromic diagnosis here. Is it a chest or is it something else? 1, 2 is look for perm caths or something. Quickly look at the skin and all that. And third is if I have not been able to localize anything, and if it's just a severe neutropenic fever which is causing the patient to go into sepsis and septic shock. There was a Marino trial which had come up, which though it was not in neutropenic setting, but which talked about patients who are organisms which are sensitive to piptazo and sensitive to meropenem also, and it clearly showed that patients who are sicker or higher risk or comorbid, their meropenem scored much better than piperacillin. Yeah. So here I would definitely use a carbapenem. But also if the patient has history of multiple hospitalizations in the past, I'm not scared to use a polymyxin B therapy because here till pending blood touches. Okay, I would say till pending blood. I would like to hit hard because this patient not going to give you time. So if there is a previous history, I would send a stool CRE, just a quick stool CRE. I wouldn't be hesitant at all if the patient has even had one admission in the past to use a polymyxin based therapy with carbapenem or tigecycline, because I think the life is more important. 48 hours later you can always think what you want to do, whether you want to de-escalate or downgrade. But at this juncture, saving the life will be very important.
Yeah, so how many among the panels are with piperacillin, tazobactam, and how many with polymyxin and meropenem plus minus polymyxin? I just want to know.
I'm with
Meropenem.
Yeah, I mean, being from the hematology background, I would go with what he said. I mean, that is what we practice at KDA.
Yeah, exactly.
So we'd go hit hard first, start with all the antibiotics, and then de-escalate later.
Yeah. You'll have to go to a carbapenem plus something like colistin or polymyxin, and then based on what your cultures show, you can de-escalate.
Yeah, exactly. So this lady has been started on meropenem and teicoplanin since her BP is borderline, and after 48 hours, she recovered well. So I just want to know from each panelist, what about neutropenic diet? We just heard to madam's lecture about neutropenic diet. So is it really, like even in my hospital, my diet, they write neutropenic diet. So I just wonder what exactly is neutropenic diet? So anyone has any thought process about neutropenic diet in febrile neutropenia patient?
So we don't recommend it in solid tumors at all.
We use it only in the bone marrow transplant
Yeah,
setting.
bone marrow, I'm not talking about the HSCT part.
Sorry, it was exactly HSCT.
No.
That is what we will use it mainly for.
Yeah. So exactly, rightly pointed out by Dr. Manju madam that there is no per se role of neutropenic diet. In fact, we are actually losing all the essential ingredients, vitamins and all if we give neutropenic diet.
Be raised during the panel. If Dr. Manju is here in the audience, I think she must be taking rounds. If any of the panelists can take it, environment related febrile neutropenia or can be the prevention of febrile neutropenia. There are studies done, the distance of the ward from the OT or from the ICU and the bug getting isolated, and air conditioning system, how frequently it is done. Especially in the south of India, there was, I forgot the hospital, where the wards are non-air conditioned, and they said even the third generation cephalosporin alone are still working in those patients. I would like to have the comments of, especially, I agree all our ICU specialists are moving towards polymyxin B, especially in this patient of solid tumors jumping on meropenem with polymyxin B. May be correct. I am not saying that you are wrong. What I am trying to say is that what after polymyxin B? So there may be some environmental factors which people can comment on.
I've worked in South for more than 18 months, and I see the pattern of resistance across India, whether it's north, south, east, west, is the same. So I don't see third generation cephalosporins, definitely I don't see any role at all. Yes, if the patient was clinically stable, I would go with peptides or meropenem only. But here, the patient has been in septic shock. I don't think it's going to give you any time to think about what we're doing. So I don't know individual studies where, I think overall, if you see the pattern of resistance, because I had a pan microbiologist India, and we saw that the resistance pattern across for majority of the organisms, whether it is Acinetobacter or Pseudomonas, E. coli, Klebsiella, is being more or less the same. The pattern of resistance, it's going worse and worse, I would say. I don't know what I have to say in Hinduja.
I think our problem are the endogenous flora, the gut bacteria, and otherwise hospital flora that are actually spread through fomites and hands. So the ventilation system has very little to do with. Sorry.
Yeah. Panel is saying that AC duct has got nothing to do with sepsis?
No, just a minute. We are moving, at least in the hospital that I work at Jaslok Hospital, we are moving to treat a lot of these patients in negative pressure isolation rooms. All right, that means not only do you have HEPA filters, the total amount of cycle changes per minute, if you have a normal air conditioner, that goes to 40 to 60 cycle changes. A negative pressure isolation room goes to 4, 5, 6 maximal cycle changes. So there's the rule of HEPA filters, there's the rule of cycle changes, there is the role of another 3 things. And that is what makes a negative pressure isolation room so crucial. That means anybody coming in, whether you're administering an antibiotic or providing meals or food or whatever else, even a relative who's coming in does not get into a personal contact with the patient. All these measures are important in minimalizing. I mentioned in the talk that I was giving that there is a role for looking at the patients who are going to elaborate the MCR1 and the MCR2 gene or the MGR gene. All of this is, they are going to confer resistance to the last line of antibiotics, including colistin, and that then you are left with, as Vasant was just saying, you are left with no real choice. You've got no real choice, you've got no antibiotics. So the thing that you probably want to work on is what is going to make all these things worse. You try and see if they can be managed in a negative pressure isolation room for the period of the crisis that they are going through during an infection.
Yeah. So last comment from sir.
So these ventilatory systems are double-edged swords. And then you understand what I mean by that. I mean, you need them, but at the same time, you need to be very careful that maintaining you got to talk to your engineers all the time. If you don't, you are asking for trouble.
Yeah, thank you. Thank you very much. With this, we end our panel discussion. Thanks to all my panelists, delegates, and organizers for giving me this opportunity.